I'm Dr. Omar Bey, and this is A Moment in Medicine. Our focus is health, education, and wellness. Our goal is for each and every one of us to have that opportunity to grow old in good health. Welcome to our show. I'd like to talk about caring and sharing. Sharing in a way that we come together and navigate this maze of medicine. And a way that we can do that is we can talk about our med moments. What's a med moment? Those are those times when we may have chest pain or shortness of breath. That's little something that makes us realize that we should go to the doctor. Our med moments, we are just like everything. We all have stories to tell. So we can talk about our med moments. Let's go to www.medmoments.com. Let's come together and do some sharing and caring. We have a great show for you tonight. We have, and our topic is gastroenterology. And we have an expert in the field, Dr. Godwin Malukwu, who's going to talk about this particular topic. And we were going to gather all his knowledge so we can understand the topic a little better. Dr. Malukwu, welcome to the show.
Thanks, Doc.
All righty. You know, this is an interesting topic because so many of us have reflux and abdominal pain or whatever it may have, whatever it may be. But the first thing I would like to know is, what is gastroesophageal reflux?
Okay, thank you. Gastroesophageal reflux disease, also known as GERD, is a chronic condition. Can manifest in so many ways, both in esophageal and extraesophageal tissues. It's a chronic condition, can be seen in any age group, children and adults. There are several causes of gastroesophageal reflux disease. The most important aspect of what we call GERD is the lower esophageal sphincter function.
Okay, hold on just for a second. Let's just go back because you mentioned several things there. Now, when you say lower esophageal sphincter, all right, let's set the stage for anatomy for everyone.
Correct.
When we talk about the esophagus, what part is? I know we eat food and we swallow.
That's correct.
Now, where does the food go once we swallow it?
Okay, let's look at esophagus as a muscular tissue. Think about esophagus. If there's no esophagus, what could have happened to many of us? You can imagine. We will not be able to enjoy the solid meal, or the hamburgers and cheeseburgers and all kind of stuff. We won't be able to transport them from the oral cavity to the GI tract.
Okay, so you're talking from the mouth to the stomach.
To the stomach.
All right.
So esophagus is huge. It can take a lot of insult. I mean, you talk about 3 different sections of the esophagus: the upper esophagus, the middle esophagus, and lower esophagus. Each of them have specific functions, and the cell types are different.
Okay. Now, once the food goes into our mouth, we swallow it.
Right.
And then it goes down into the esophagus, and it goes through the 3 stages of the esophagus.
Right, through the muscular tissues. Right.
Now, it dumps into the stomach, the food.
It dumps into the stomach.
Now, what happens between the stomach and the esophagus? How does that all work? Because it must be something that's holding it all together there.
Very good. That's what we're going to talk about, really. You have the upper esophageal sphincter and the lower esophageal sphincter.
What's a sphincter?
Sphincter, the way I would like to describe sphincter is like a shut-off valve.
Oh, all right.
Right.
Like a shut-off valve.
Right. Okay. Think about shut-off valve. What happens, I mean, many of us can hold the food in the mouth for whatever reasons. One of them is stroke, and they will not be able to initiate the swallowing mechanism. Okay, you have the one that we're able to control, and the one that we're not able to control some of the functions. But as soon as the food hit the upper esophageal sphincter, we've lost that control. What happens is, so you can imagine what happens in the absence of upper esophageal sphincter. Where would the food go to? There's the trigger, there's the mechanism. Part of the functions is controlled by the brain. Okay, we can get to that at some point, but as soon as the food, lower esophageal sphincter opens, the food goes, is a reflex, happens so fast, and the food will transit down. That's the upper esophageal sphincter. The upper esophageal sphincter muscle is in continuity with the oral cavity muscle. Okay? And then you have the middle esophagus. The middle esophagus is more of a combination. The proximal and the distal is more. The proximal is part of the oral esophagus muscular tissue. The middle, towards the end, is in continuity with the stomach, which we're going to get into. So the middle esophagus, and then halfway to the esophagus, what happens is that there's a message that will be sent to the lower esophagus that something is coming. So it's going to get ready to open, to dump the content of the esophagus into the stomach. Esophagus, the whole system happens so fast, okay? Because esophagus is not really meant to handle food for so long. It's got to move down through what we call peristalsis.
Okay.
So we can get into that.
All right. So peristalsis, you hit me with these nice words. I just love these medical words. Peristalsis, it means like you're pushing it along. Right. All right.
It accelerates the movement, and then you think about what happens when the food gets stuck in the esophagus. You see, then something must have happened to that motion, that movement, and then there's a lot of stuff that can really affect the esophagus. There's a lot of disease out there that can decrease the peristaltic contractile motion. We can get into that at some point. But peristalsis takes the food down, and by the time the food is halfway, the lower esophageal sphincter opens.
Right.
Okay, and then the content of this esophagus is dumped into the stomach, and guess what? It closes, so that the content of the stomach, the same stuff that went down, shouldn't come up.
Okay.
If it does come up, that causes a lot of damage to the esophagus, because right now there's a mixture of the food and what was left in the stomach, and the acid production, the pepsins, the fat, all kind of stuff, all the stuff that we enjoy. Some of them stays in the stomach, and then they come up. Reflux disease.
Okay, so let's set the stage here. Let's set the stage. Now, when the food dumps into the stomach,
that's correct.
That muscle, that sphincter, as you call it, closes off.
Close it.
So that once the food dumps into the stomach, then you get all of the stomach acids coming about.
Right, because you need acid to extract some nutrients from the food, and then the initial digestion begins right there.
Okay.
Okay. Right. There's a lot of stuff. Acid is very important. It's not as bad as people think. We need acid.
Okay.
To kill the bacteria and extract vitamins and minerals from the food. That's correct.
All right. It's interesting. So we need acids. Like the food that we eat, we know bacteria is everywhere.
Right. That's correct.
And we eat the food, and once that food gets into the stomach, in order to kill the bacteria, the acid helps kill the bacteria.
Acid is very important. People think that acid is something that no, we need acid. We need some acid to initiate the process of digestion.
Right. Now that acid, does it help break down the food as well?
Well, remember that the process of breaking down the food begins in the oral cavity.
Oh. Yeah, the oral cavity means the mouth.
The mouth.
Right.
There mastications, and the salivary gland will helps. And so digestion begins in the mouth, really.
Okay, all right. So this is so interesting, because when you say salivary glands, you mean the mucus or the whatever the saliva that we produce in the mouth comes from our salivary gland.
That's correct.
All right.
That's correct.
And that starts breaking down the food at that point.
That's where digestion begins.
Oh. All right then. Now let's talk about this reflux part of it, because this is so interesting to me.
That's correct.
You know, the food comes into the stomach. Now, at what point in life, or is it that we get old and the muscles get weak? It's like a car, you know. You drive it 100 miles, and after a while, you know what I mean, the motor starts to shake a little bit, you know. So I think our bodies are similar. You know, we drive them for quite a few years, but everything doesn't work quite as well as we'd like for them to. So is that what happens? The sphincter just doesn't close, or is it what happens that allows this acid to come back up into the esophagus?
There are several reasons to that.
Okay.
You'd be surprised to know that acid reflux also happens in children, in babies.
Oh.
Babies that are born today do experience acid reflux and complications. What I mean by complications, I mean esophageal and extraesophageal complications. So, for instance, mothers will take their children to pediatricians because they're not gaining weight, they have stomach discomfort, and studies have shown that a lot of children, babies I mean in this case, do experience reflux disease. So acid reflux disease is the cause of reflux disease is a combination. There are several factors that plays into that. One of them, which I think is the most important, is the lower esophageal sphincter tone or function. Okay, and then and that's why doctors advise their patients certain things that they need to do when the lower esophageal sphincter becomes incompetent for reasons like we gain too much weight, and we eat at odd times, and stress. A lot of factors do affect reflux. I don't want to move too far away, but
no, go right ahead. Go right ahead.
So yes, we advise our patients to make some lifestyle changes because we know that those changes, in addition to medical therapy, does help with acid reflux. So I hope I'm getting to your question. Acid reflux can happen in any age group.
Right.
Okay. The older we get, the sphincter gets weaker, just like everything in life. And the babies, their sphincter, as far as we understood, wasn't properly developed. So as time goes on, they have less reflux, and the older we are, the sphincter gets weaker, and then the content of the stomach tends to come up into the esophagus and does a lot of damage to it.
Alrighty. Now, let's step back just for a minute.
Correct.
Now, we understand that this sphincter, they're supposed to close like a muscle and close off and inhibit or prevent that acid from refluxing back up into the esophagus. Now, when that acid refluxes back up, is that heartburn?
Typical.
All right. Exactly. Tell me about this heartburn. What's happening there that's causing me pain? Because I tell you, sometimes I'm running for the Maalox.
We all do. We all do. I have heartburn myself. But what happens is that, remember, the lining of the esophagus is different from the lining of the stomach.
Oh, okay.
Okay? So the different cell types. A typical example is that the esophageal lining is more of what we call columnar shape type. The stomach is more of intestinal type. Esophagus is not meant to handle anything that comes from the stomach up.
Okay.
It's not meant to handle that. So what happens is that when acid comes up, okay, and there's absence of peristalsis, absence of saliva to neutralize, because it's neutralize the acid in the stomach, in the esophagus, patient will begin to feel burning sensation, tightness in their chest, and that's reflux and heartburn.
All right. So let's just understand this. The stomach has a certain type of cells or tissues that can handle that acid.
Yes. Oh, yeah. They can take a lot of resilience. That's correct.
The esophagus has a different type of cells that make up the tissue. That once that acid refluxes back up, it actually, burn those tissues?
Tissues. It tend to destroy them pretty much. Yeah. And then it can even transform those cell types, trying to change them into stomach cell types, known as intestinal type.
Oh, interesting.
We're going to get into the consequence of that.
Okay, all right then. Now, I know that in my field, pulmonary, I see a lot of patients in the office, a fair amount, that have bronchitis.
That's correct.
And I know the one thing that I always ask is about esophageal reflux, because that just one little drop of that acid from the stomach that gets down into the lung, maybe you're sleeping and it flushes back up while you're laying supine or as flat. I know that burns the lung.
It does.
And it can cause bronchitis. It burns the airways and cause bronchitis. How strong is this acid? I mean, it must be very strong.
It's pretty strong. Okay, for those of us who handled acid in the lab, we talk about 0.1 nanometer, whatever figures that they use. Yes, those acids, not only that they can cause damage, they can cause hoarseness, they can sore throat. Patient wakes up in the morning with sour taste. Those are what we call the extra esophageal manifestation of acid reflux. Okay. Yeah, they can cause pneumonia, sleep apnea. As a matter of fact, it's known to cause apnea.
Oh, all
Okay.
right. Now, apnea, you hit me with another big word. All right. But that happens to be in my field. So
Please.
apnea is that period of time while you're sleeping that you actually stop breathing.
That's correct.
Just
For a
for a
couple of
short
seconds.
period there, you stop breathing. And the oxygen in your blood actually decreases significantally because
That's
you
correct.
stop breathing.
That's
So apnea. So esophageal reflux has a play as far as
It's
that's
big
concerned.
time. It's well known. It's well known to cause that. One of it's even known to cause growth retardation in children, babies.
Okay. Now, what about? I know a problem that we have, especially I shouldn't say most. A lot of our patients that come in are overweight.
That's correct.
Now, does this play as far as being overweight is concerned? Are patients that are overweight more likely to have reflux or more likely to have problems such as this?
They're more likely because we know what effect it does have on the lower esophageal sphincter tone. It decreases the tone. Yeah, overweight is a part of the contributory factors that can worsen acid reflux. That's why we advise our patients, part of the lifestyle change, I'll tell my patients is to lose weight. Among other things.
What are the most common symptoms? I know you're a biased sample because basically you see these patients all the time. When they present to your office, what do they present with? So that the audience understands if they're having a certain symptom, maybe they should think about it. How do they present if they have this?
Doc, remember this, before we see these patients, most of them have tried a lot of stuff before. Patients are very smart. We shouldn't underestimate them. What happens is that they tend to treat themselves.
Right.
Okay, they use over-the-counter medication, antacids, and then at some point they don't get better. That's when they go to the doctors. What I would like to see would be to catch them at that stage. But those ones that came to us, when you sit down and talk to them, they're interested. They talk about burning sensation, chest pain. They describe. They say it was like held their hand on the chest, trying to demonstrate the severity. So burning sensations, heartburn, chest pain. They come in with some of them said even I can swallow. It feels like something gets stuck on my throat. And someone that I saw yesterday, a lady. She said, Dr. Muluk, something got stuck on my throat. I have sore throat. When I looked at her throat, I could tell right away that she has long-term acid.
Like the acid was coming up and burning the back of her throat.
Right,
so it was swollen back there, it was red.
Was red. Typical of
looked irritated.
Right, exactly. So the patient presents, but like what we were talking about was a burning sensation, pain on their chest.
Right. Now, what about odor in the breath? As far as that, I remember when I was a child. I was a teenager actually, and I had a friend, and we used to call him Bobby Bad Breath.
Yeah, that's well.
Because we used to call him that because he had an odor all the time, and then he actually went to the doctor, and he had esophageal reflux.
Yes.
That's a common. Part of this syndrome as well?
It does cause bad breath. Patient wakes up with sour taste, acid taste, and the breath, yes, is known to cause bad breath as well as a sour taste in the mouth.
Let's get the treatment. First, before treatment, I love this. Let's get the diagnosis. How do we diagnose it? Do we need a procedure to diagnose it? How do you diagnose? If somebody, how do you know?
History is very important. Just sit down and listen to the patients. Okay, so fancy tests, X-rays, and endoscopies should come later.
Right.
As a matter of fact, we do those to reassure the patients that or rule out a couple of other things. But history is just as good as everything else, and patient comes in with a very good history, and you shouldn't really, unless they're what we call the alarm symptoms, you shouldn't really scope these people. You should try them on medications, and if they don't get better, or they have what they call the alarm symptoms, or their age, then you should pursue X-rays, endoscopies to rule out complications.
Okay, all
so
right.
history is very important.
All righty. We'll get to complications in a minute.
Correct.
But let's talk about treatment.
Okay.
When you're starting a patient on treatment, I know, as you say, our patients are smart. They really are. People are smart, and they're used to taking care of themselves. They've already tried probably the Malox or something like that.
Over-the-counter antacids.
Right. So when they come to you, what do you do at that particular point as a physician?
Okay. Again, history is very important. Tell me what you've done, They say, well, doc, I've used Tom, I've used this and that. What I'm realized is that my symptoms goes away and comes back. Okay, I say, what else have you done? Have you changed the way you eat? Have you changed certain food that can trigger your symptoms? They say, yes, I did. At that point, okay, there's a stepwise procedure or protocol that we follow. Okay, well, you look at, do they have insurance? Can they afford those medications? Because what people need to understand is that those medications are very expensive, especially what we call the PPIs, the proton pump inhibitors. They're probably one of the most expensive, commonly prescribed medication in this country. Okay, so before you treat them, you have to factor in, can patient really afford? For example, if we put them on those medications that are very expensive, can they afford it? Can they take it? Okay, so those decisions need to come into play. You could start with H2 blockers, okay? Or what I would like to do in my case is make some lifestyle change. What I told my patient is that, and as far as I'm concerned, medication should not be the first, or medical therapy should not be the first. You have to do some lifestyle changes.
Okay, so let's step back now.
Right.
All right, lifestyle changes, that's all well and good.
Yeah.
But if I'm sitting here as a patient and I'm saying, so what should I change? You know what I mean?
Right.
I understand what he's saying, but give me a clue of what I'm doing wrong. So, because, if you get that chest pain too many times, you're willing to do just about anything to get rid of that crushing feeling.
Okay, remember when I said age is very important, okay, because yes, acid reflux is probably one of the most common causes of atypical chest pain. Atypical. So what's typical? Typical is what you make sure that they're not having heart attack.
All right, so you're talking about when you say atypical, what you mean is any chest pain that doesn't mean that it's a heart stimulated pain.
That's correct.
If it's not the heart causing the pain, it's atypical.
It's atypical.
Gotcha. All right.
So you need to rule that out. Again, age is very important. Underlying medical conditions are very important. Okay. So again, you gotta take a good history from your patients.
Right.
You look if they have diabetes, hypertension, and when their age is appropriate for coronary artery disease. You rule those out. Okay. Because those are more likely to kill them instantly than gastroesophageal reflux disease.
Oh, all right then.
You rule that out. Medications, lifestyle change, followed by medications.
All right then. Well, let's talk about this also. I know that there are certain medications that the doctors prescribe, but also things like positioning in bed,
right?
Not laying flat.
It's part of the lifestyle change. Elevate the head of the bed. Don't eat. If you go to bed at 10 p.m., stop eating after 6 o'clock. Give yourself time to empty the stomach. And if you overweight, lose weight, there are food that we know that trigger or can worsen acid reflux: coffee, alcohol, tobacco use. You need to stay away from those or minimize them right before bedtime.
Okay, excellent.
Part of lifestyle change.
Oh boy, this has been such a good educational aspect today. I'm just so glad that we had you on the show.
Thank you.
And I look forward to having you back because there's so many other topics that we can talk about as far as GI is concerned.
Thank you,
Dr. Nluku, thank you very much.
Thank you so much for inviting me.
All righty. I'd like to have just a Let's Talk segment just for a few minutes. And the reason I want to have this segment is because I got an email the other day. And there was a particular interesting email that I got, and someone asked me about isolation. They went to the hospital to visit a family member. And the first thing the nurse said to them is that you had to put a gown on before you could enter the room to see their family member. And they were very upset about this. And so they emailed me and wanted to know, could you just talk a little bit about isolation? And I said, yes, I would, because I think it's an important topic. All righty, so we have just a few props here. Number one, there are 3 types of isolation. Number one, there is reverse isolation. And reverse isolation is isolation where the patient may not have the ability to fight infection. And infections that we bring to them may be harmful to them. Now, patients with cancer or who are getting chemotherapy, these are examples of patients that their immune system may not be as sharp as it should be, and they may not be able to fight off bacteria that we bring and expose them to. The second is contact isolation. Contact isolation means that the patient has a bacteria that the hospital they don't want to spread that bacteria to other patients. And so what we'll do is we'll have you gown up and put gloves on and put a mask on and go into the room so that you can protect yourself as well as other patients from getting that particular infection. The third is respiratory isolation. And respiratory isolation is when you have an infection that if you cough, you will expose that person to a particular bacteria. Well, we're going to go fast here because we're running out of a little time, but when you go into your room, the nurse is going to ask you to put on a gown, number one. Number two, to protect yourself as well and the patient, they're going to ask you to put on gloves, all righty, to protect your hands so that you're not spreading bacteria or they're not spreading to you. Number three is that they're going to ask you to put on a mask, and it can be a duckbill mask or it can be a regular mask that you have to tie up. And once you do that, then you're protected and you've protected yourself, and as well as protecting the patient from any infection that can come about. Dr. Maluku, I'd like to thank you immensely for coming on the show. Thank you very much, and I'm looking forward to having you back.
I'll be more than happy, and I would like to come back.
All righty. In closing, I would like to say that never institute any change in your medical therapy until you talk to your doctor. And I trust each and every one of you continued good health. I'm Dr. Omar Bey, and this is A Moment in Medicine. Until I see you again, or should I say until the next time, peace to you all. Thank you. Thank you very much, Doctor. Thank you very much.